Hey everyone, welcome back to the DNS podcast. On today's episode, we're discussing bone mineral disorder in patients living with chronic kidney disease. This condition affects bone health, mineral balance, and can increase the risk of fractures, cardiovascular disease, and mortality. Nutrition plays a central role in management, but the complexity of the condition can make treatment difficult for both patients and their caregivers. Today, we're joined by Sarah Gilbert to talk about the role of dietitians in particular in supporting patients with bone mineral disorder in CKD. Sarah is a registered dietitian nutritionist and doctor of clinical nutrition student at the University of New England. She brings nearly a decade of experience in renal nutrition, clinical practice, and higher education, and currently serves as dietetic field coordinator and clinical assistant professor at the University of New England. With 6 years specializing in hemodialysis care, Sarah is committed to improving outcomes for patients with CKD. She's also an active leader in her profession, serving as past president of the Maine Academy of Nutrition and Dietetics. She's passionate about advancing evidence-based nutrition care, mentoring future dietitians, and translating research into practice to improve patient outcomes.
Coming to you from the Dietitians and Nutrition Support Dietetic Practice Group, this is the DNS Member Podcast, where we explore topics relevant to our field. From support line content to nutrition celebrity interviews and everything in between, this podcast is where DNS members can go behind the scenes and explore the driving forces behind cutting-edge nutrition support. I'm your host, Christina Rollins. Let's get started.
Sarah, thank you so much for joining us today on the DNS podcast. I'm so happy that you're here with us.
Yeah, thank you so much for having me. I'm excited to be here.
So let's start, if you don't mind, with a quick overview of what bone mineral disorder and chronic kidney disease is, and why it's such an important area for dietitians in particular to understand.
Yeah, so by definition, chronic kidney disease, bone mineral disorder is a systemic disorder involving abnormalities in calcium and phosphorus, parathyroid hormone, vitamin D, as well as bone turnover or mineralization defects and vascular or soft tissue calcification. So it's a whole range of issues that are happening. And the reason that it's really so important for dietitians to understand is because some of these biochemical changes, of course, are influenced by nutrition, like phosphorus is a really big one. So when the kidneys aren't working, particularly when somebody is in stage renal disease, phosphorus then that we eat, from food gets absorbed and builds up in the blood, and then this then causes the calcium levels to drop, and then low calcium then stimulates the parathyroid gland to secrete more parathyroid hormone. So it's a cascade and like a tidal wave, if you will, that really just leads to bone reabsorption and skeletal weakness over time, and eventually also leading to calcification of blood vessels and soft tissue. And dietitians play a pretty big role in managing this, and it's not just in terms of diet education, but depending on state licensure, they help manage the bone mineral medications that the patients are on too. So it's a pretty involved process, but the dietitians play a big role in it. So pretty important to know the full system and how it works.
What are the main nutritional factors that really influence the bone and mineral balance, specifically with CKD patients?
Yeah, there's a few factors. And so I briefly there talked about phosphorus, and that's a big one. And kidney function declines, phosphorus excretion decreases, and that leads to then hyperphosphatemia. Then that hyperphosphatemia starts that cascade that I mentioned with the dysregulation of calcium and the parathyroid hormone. Then there's the calcium too. That's an important part too. So too much or too little calcium can worsen bone disease or increase that calcification risk. And then there's also vitamin D. So that metabolism is altered. And with declining kidney function, inactive vitamin D just it can't be activated as efficiently, if at all, really. So the interventions focus really on just correcting those deficiencies and then using active vitamin D analogs like calcitriol if needed.
So how do you approach counseling your patients about phosphorus management in particular when their bone mineral disorder is present?
Yeah, so phosphorus control is definitely one of the biggest challenges. Um, and my approach is always individualization. So everyone's diet and needs are a little different. So I try to tailor their phosphorus education to meet their needs as best I can. I might educate them on the different absorption rate of like inorganic versus organic phosphorus, or try to talk to them about what I call the three Ds, diet, dialysis, and drugs. The three Ds work for all patients, but especially in that end stage renal disease stage. So diet, as we know, can be one of the ways that we manage serum phosphorus. But then there's dialysis. So hemodialysis and peritoneal dialysis treatments help manage the phosphorus as well. And then the drugs, and that's in the form of phosphorus binders. So that's another way. So looking at phosphorus control from that whole picture is really important just to see what we can do to help manage it. But lastly, I try to tie it back to the why with the patients, right? Why do we care about phosphorus? So letting them know why managing it is important, and just the risk of what happens if it's not controlled for a sustained period of time. And you don't want to do it just to scare them, but really just to help them understand the whole reason.
Well, it is a little bit disorienting because, if a patient drinks too much milk or, has too much phosphorus in their diet, they're not going to feel sick immediately, right? It's not like that immediate reaction that tells me like, oh, I need to stop, right? Like it's
Yeah.
going to take time to build up before they see those
Yeah.
consequences.
Yeah, so it doesn't necessarily feel like an important thing to work on right that second. So it's an important thing to especially when they're first starting dialysis, to really kind of talk about it and say, like, I'm not just harping on this for a reason with you.
Mhm.
This is what can happen, and the consequences aren't easy to deal with once they do actually happen. That, vascular calcification is nasty stuff, and if we can avoid that, we want
Mhm.
to.
Yeah, it's not like I had too much salt in my diet and now I'm swollen and
Yeah,
I
yeah,
better do my diuresis, whatever. It's not like
yeah,
that.
exactly.
So, talk with
Yeah.
us about the role of calcium and vitamin D and how we can help balance supplementation with the patient's diet and also looking at their lab monitoring schedule.
Yeah, so it's a constant balancing game between those two. So phosphorus retention and then the reduced activation of vitamin D results in those low calcium levels, again, triggering the parathyroid gland. So in the dialysis setting, dietitians play the role in helping manage that. And of course, there's diet education again, but when you're talking to them about calcium, you're going to educate them on their daily intake of calcium. So we recommend generally about 800 to 1,000 milligrams a day with end stage. You may also, though, find then that patients, it's not just dietary calcium. They're on things like Tums or just a general calcium supplement too. And these are okay as long as the serum calcium stays in range. Once that value then becomes either high or low, is when you start to work with the patient on adjusting whatever needs to be adjusting. And then something to keep in mind too, is especially in the end stage and they're on dialysis, is vitamin D analogs. This is when that typically gets started. And so when active vitamin D is started, this can increase the intestinal absorption of calcium. So you really just have to watch out then for hypercalcemia. And then in general, in dialysis, the labs are really frequently monitored. And so because of that, we adjust the vitamin D and the calcium pretty frequently, based on whatever the lab says to do, really. And that's all done by the dietitians.
So, we know that many patients will struggle with phosphorus binders, right? Because you're adding it in the mix, you have to take it, repeatedly, right? It's not just like a one and done thing. So how do you support patient adherence to their phosphorus binder regimen, and really help them integrate these meds into their lifestyle?
Yeah, it's probably one of the biggest challenges they face.
Mhm.
Um, I personally think it would be a big challenge if I had to take a binder for every time I ate something. Um,
And these are not small pills, right? Like they're
they're
pretty big.
huge. They're huge. Yeah. And you're usually taking more than one too. And yeah, it's not just like a blood pressure medication that you just take in the morning or at night or something. It's
Mhm.
only when you eat. So I think the biggest thing you can try to do is individualize as much as you can. Obviously, the diet education you're going to individualize, but and meeting them where they're at for diet. Um, but in recent years, there's in general a push towards diet liberalization as opposed to restriction. So that's been a big help in terms of getting them a little bit more on board with just trying to help manage their phosphorus, is that not all the foods are off limits. Patients would frequently ask me if a certain food was okay. I never said no. I always said yes, you could eat that. It's okay. But in addition to the diet individualization is medication individualization. So there's different binders, and each binder they do the same thing in general in that they're absorbing phosphorus, but they're still slightly different. So whatever the patient needs, trying to match the binder to that would be as beneficial as they can. And I always try to like give the patients options. So here's a couple of binders that I think would be best for you. Which ones do you want to choose? Which one do you want to try? And letting them select that, I think, gave them a lot of autonomy in the matter. So, like, I chose it, so I want to try it, so I'm going to take it as I
Mhm.
should. I think that plays a big role in
Mhm.
just letting them be kind of the leader in their health.
Yeah. Well, and what about like when you are doing that diet education and reinforcement? We're encouraging high protein, especially in the dialysis population, but some of those foods may be high in phosphorus. So how do you balance that for them?
Yeah, protein essentially doubles in the end stage versus those earlier stages. So you're looking at 1 to 1.2 grams per kilogram a day. In peritoneal dialysis, it's even higher. And one thing I always told patients is that if there's protein, there's phosphorus, but not all phosphorus is created equal. So I kind of touched on it earlier that there's inorganic and organic phosphorus. And organic phosphorus is what is naturally found in animal or plant foods, but it's less bioavailable. So only about 40 to 60% of that phosphorus is actually absorbed. And then you have inorganic phosphorus, and that's the phosphorus that comes from your additives, those processed deli meats, packaged goods, and essentially all of that phosphorus is absorbed, about 90 to 100%. So overall, talking to them about the type of phosphorus really matters, I think, to these guys.
And what about patients? Because we know this happens a lot where they're not just in renal disease, they've got diabetes or cardiovascular disease. What's your approach to helping them balance maybe all of the different recommendations that they're getting from their various providers?
Yeah, probably my favorite word, individualization, which I said
Mhm.
a few times. That's really a big idea with renal nutrition in general. So individualization is pretty key in the KDOQI guidelines. They really enforce that of individualizing as much as you can. And the one thing that will help with that individualizing education will come from the labs, right? So once you see the labs, then you can adjust their intake based on help them adjust their intake based on whatever it needs, whether it's more or less. And one thing I remind the patients is to look for the common ground between different comorbids too, and
Mhm.
and their diet recommendations that go with those other comorbids. So for example, like a patient would worry about their diet because they also have to control their high blood pressure. And I would use that moment and say, well, guess what? That is done with sodium restriction. And also that's needed then in the renal diet as well. And then for conditions like diabetes, I still try to tie it back to how it could affect their kidneys and their current health then at that stage. So I try to reinforce like how uncontrolled blood sugar then could lead to feelings of increased thirst, that would, then when your kidneys aren't working, that leads to increased fluid gains. So I think just tying all those things together just helps the patient feel a little less overwhelmed because they are typically not in there just with end-stage renal disease. There's lots of other things going on. So tying it all together in any little pieces that you can, I think helps feel, takes some of that pressure off of them.
And what are some of the biggest misconceptions that patients or even other healthcare providers may have about bone mineral disorder in CKD along with nutrition?
Yeah, I think one of the misconceptions that really comes to mind is just that bone disease is about calcium and vitamin D, and that's it. And it's really much more multifaceted than
Mhm.
that. It's a systemic disorder that, yes, it involves calcium and vitamin D, but then there's also phosphorus and parathyroid hormone, and managing that requires balancing all of them and not just calcium and vitamin D. And the dietitians really just they take the lead in managing it. It's really well within our scope of practice to be able to work with these. Um, and then for patients, I think a big misconception is kind of what we already talked about is that the effects aren't immediate. So they don't think that it's as important. Um, or they also think that it's just about the bones, but it's also about the vascular system that can suffer the consequences too. So I think those are really the big things that, especially like I kind of mentioned earlier, that might be the big focus on that education, especially in the beginning, is finding that misconception that they might have about it's not that big of a deal that I don't need to take it and working through that to make those longer term goals, changes.
Well, I really love this topic because I feel like this is like the perfect case study in how dietitians are perfectly positioned to look at like the big picture, right? And offer this individualized patient-centered care. And I think you paint a really nice picture of that and how effective these targeted interventions can really be in a patient's lifestyle.
Yeah. Yeah, I do. It's always been these patients always have a place in my heart with
Mhm.
it. And it's it's a it's a unique world to work in that yes, you're working on so many different aspects of of the patient's health, and it does allow you to make a pretty big difference in their lives too.
Well, you've got a ton of great experience really working in the world of hemodialysis. So, what strategies have you found to be most effective in engaging your patients and really partnering with them to achieve those improved long-term health outcomes?
Yeah, I think getting on the patient's level and really working with them on what they want is how I always try to kind of work with them.
Mhm.
So, what do they want out of doing dialysis, and how can I help them get to that point? I try to involve them as much as I can in that bone mineral management process and their interventions and selecting what they would like to work on and what they want to do. And if we needed to change those phosphorus binders, like I said, I'd give them options or something. So just giving
Mhm.
them that autonomy, I think was pretty effective for those patients. Um, and then in addition to that, I think just being realistic with what they want and what they can do to make positive behavior changes. We're not expecting them to change overnight. We're not expecting them to fix every little piece of their diet. Nobody's perfect. And so I think, again, with the KDOQI guidelines being much more, focused on diet liberalization instead of restriction, I think it makes it much easier to create interventions for the patients.
Well, looking ahead, what areas of research or practice do you think hold the most promise in improving the management of bone mineral disorder in the CKD population?
Yeah, I love this question because my answer is that I'd love to see more phosphorus binder options. So I'd love to see more research in that area and the development of these binders. Because right now there's only so many options. And then for the patients who need a little bit more than just diet, adjustments for their phosphorus and they need that medication management for it, there's only a handful of options. So, and they might not work for everybody. So finding, a few extra, different types of binders would just be awesome. There's been some new binders over recent years that have come out, but overall it's still pretty limited.
Well, we have a very dedicated audience, I think, on this podcast and with the DPG. So hopefully somebody is listening that shares your passion and can take that ball and run with it. That would be amazing.
Yeah.
If you're listening, it's time to do the research. Well, Sarah, thank you so much for sharing your expertise and your experience with us today. Bone mineral disorder and CKD is such a very complex condition, and your insights really, I think, highlight the importance of our role as dietitians in improving patient care. So thank you for being here with us.
Thank you so much for having me.
And listeners, for more resources, education, and just general support, visit our website at dnsdpg.org. And if you're not already a member, we would really encourage and would love for you to join our group. So please think about it. And of course, follow and like this podcast so you can get more great content as we produce it throughout the year. Until next time, I'm Christina Rollins. Thanks for listening.